Karnataka. So on behalf of NNF Karnataka, with my colleagues, Joint Secretary, who have joined with me, we would like to welcome, and with President, Vice President, and the entire office, would like to give a warm welcome. And continuing our academic session, today we have metabolism of potassium and metabolism of calcium, which we'll be discussing, which is a very common scenarios what we see come across in our neonatal ICU. So without wasting much of time, so I request Dr. Girija, who is a consultant neonatologist and an assistant professor working at Vaidehi Medical College, and plus she's going to be a part of Amshadaya Hospital as well. Welcome, we give a warm welcome to you, ma'am. So over to you. I request you to maintain the time so that we give maximum time for discussion for our audience. Over to you. Thank you.
Okay, thank you, sir. Thank you, NNF Karnataka, for giving me opportunity to talk today. So today my topic is approach to hyperkalemia and hypokalemia in neonates.
Just click on the screen bar. Go to next slide, or on the down left hand side down, there are arrows. You see the arrows left hand side down.
Where, Prashant? Yeah.
Okay.
So coming to the introduction, potassium is the major cation in the intracellular compartment, approximately 98%, which has more for the vital for the biological functions, that is for the protein synthesis, cell growth, cell volume regulation. So you can see here at the electrolyte composition, you can see the potassium is the major cation intracellularly, almost 140 milliequivalents. Why this is important? That is sodium potassium ATPase pump. It is the most important pump for maintaining the extracellular and the intracellular potassium. It is tightly regulated by the basolateral sodium potassium ATPase pump, which maintains the resting membrane potential, which in turn is responsible for the normal functioning of excitable cells. So what in preterm babies, why do they have higher serum potassium levels? There has been a study which is conducted in less than 30 weekers and less than 1 kg babies to know the trend of the serum potassium. In this study, the maximum, like almost more than 6 milliequivalents was seen within the first day of life. The peak was seen between the 9 and 72 hours, with almost the major peak was seen at 24 hours of life, which was more than 6.7 milliequivalents per liter, which gradually decreased on the third day and stabilized from 4 to 5 days onwards. Why this trend is most important? Because hyperkalemia is related. We have to treat hyperkalemia, but to consider the age-wise and to consider the post-menstrual age while treating hyperkalemia. So immature kidney is programmed to preserve potassium. So we have to know how. So what happens in glomerulus? In neonates have low GFR, which limits the filtration of potassium. So immaturity of the tight junction alters potassium absorption through paracellular pathways in glomerulus. In proximal convoluted tubules, low sodium potassium ATPase activity decreases proximal sodium and fluid absorption, limiting the solvent drag effect. Low sodium potassium ATPase maintains a higher intracellular sodium and lower potassium. So what happens in thick ascending loop of family? There are two channels at most important, that is renal outer medullary potassium channel activity and NKCC2, that is sodium potassium 2 chloride cotransporter isoform, which are expression are low, limiting the potassium excretion in this segment. So in descending collecting tubule, the immature aldosterone sensitive distal nephron receives 35% of the filtered potassium load compared to 20% in mature nephrons. So the immature collecting duct is resistant to aldosterone. So what does it do? When the immature collecting duct and the distal convoluted tubule is resistant to aldosterone, and immature kidneys have low sodium potassium ATPase, low apical secretory potassium channels, and low epithelial sodium epithelial channels. So potassium is not secreted. So in distal convoluted and collecting tubules, there is something called as low Romack activity, which decreases further potassium secretion as physiological flow. Low big conductance potassium channel activity, which limits flow stimulated potassium secretion. So high hydrogen potassium ATPase expression in the alpha intercalated cells, which favors potassium absorption over secretion in immature collecting duct. Is what does hydrogen and potassium ATPase in the collecting duct. So what are that was the developmental adaptations in the renal. What are the developmental adaptation in the intestinal handling? Immature neonatal intestine, so there will be low activity of the basolateral sodium potassium ATPase pump, increased apical hydrogen potassium ATPase and sodium independent potassium ATPases. So low intercellular potassium, promoting net intestinal absorption, contributing to a state of potassium retention and higher extracellular concentration of potassium. So coming to developmental adaptation in the mechanisms regulating internal potassium distribution. So in preterm infants with increased potassium, they exhibit lower sodium potassium ATPase activity, that is lower intracellular serum potassium when compared to normocalemic premature infants. So preterm neonates with prenatal treatment with steroid stimulates maturation of sodium potassium ATPase, thereby preventing non-oliguric hyperkalemia without affecting potassium excretion. So that was the thing, how the kidney will program to preserve potassium during growth. Coming to hypokalemia, it is defined as a plasma potassium less than 3.5 milliequivalents per liter. Coming to classification, it has been classified as mild, moderate, and severe. Mild is 3 to 3.5 milliequivalents per liter, usually asymptomatic. Moderate, 2.5 to 3 milliequivalents per liter, may be symptomatic. Severe, less than 2.5 milliequivalents per liter, symptomatic, and it is said to be critical when the levels are less than 1.5. So what are the causes for hypokalemia in neonates? These are the most common causes, either in poor intake, where there is insufficient support in TPN, or in GI losses due to vomiting, diarrhea, gastrointestinal fistulas, or osteotomies. Increased renal losses in case of mineralocorticoid excess, Barters and Gilman syndrome, renal tubular acidosis, magnesium deficiency, drugs like amphotericin B, aminoglycosides, diuretics like thiazides and loop diuretics, steroids. Redistribution, which causes internal shift of potassium, which is seen in alkalosis, caffeine, thyrotoxicosis, theophylline, beta agonist, and epinephrine. So what are the factors that decrease potassium level? Alkalosis, by enhancing the cellular potassium uptake. Insulin, which stimulates potassium entry into the cells by increasing sodium efflux. Beta adrenergic agents increases skeletal muscle uptake of potassium. Aldosterone, which increases sodium resorption and increases potassium excretion. So coming to the clinical features, in mild, we might just see no symptoms, or it could be just slight muscle weakness. In moderate, proximal weakness in lower extremities, constipation, and abdominal irritation. In severe, rhabdomyolysis, myoglobinuria, severe muscle weakness, respiratory distress, bradycardia with cardiovascular collapse, cardiac arrhythmias, and acute respiratory failure from muscle paralysis. So what are the first line investigations we are going to send? Biochemical, it includes serum electrolytes, urinary spot potassium, or 24 hours urinary potassium, urine potassium creat ratio, and ECG. ECG, I have put a normocalemic ECG also, where you can see a normal P wave, PR interval followed by QRS, and rounded a normal size T wave, and U wave, which is rarely seen. And in hypokalemic, there will be slightly peaked P waves, slightly prolonged PR interval, ST depression, shallow T wave, and prominent U waves. Early changes in hypokalemia, which I put the first one, which is flattened T, prominent U, and low ST segment. In hypokalemia, the ST segment further descends. So what are the second line investigations? The second line investigations biochemical are serum renin, aldosterone, and cortisol, 24-hour urine aldosterone cortisol, and the drug screen in the serum and or urine. Hormones, mainly thyroid profile in case of thyrotoxicosis, radiology, pituitary imaging to evaluate for Cushing syndrome, adrenal imaging to evaluate for adenomas, and evaluation for renal artery stenosis. So if the cause is apparent, like the above causes we know, we'll be knowing what is the cause for the hypokalemia. What should we do if the cause is not apparent? Like urinary potassium spot or 24-hour potassium or urine potash create ratio and ABG should be done. So 24-hour urine potassium excretion, if it is less than 15 millimole per deciliter, that is urine potassium, urine creatinine ratio less than 1.5, most common due to GI losses or hypokalemic periodic paralysis. If it is more than 15 millimole per deciliter or urine creatinine or urine potassium to urine creatinine of more than 1.5, high BP, raised aldosterone to renin ratio and raised aldosterone causes primary aldosteronism. If with high BP, low aldosterone, low renin, the cause is 11 beta hydroxylase deficiency, 17 alpha hydroxylase deficiency, Liddle syndrome, apparent mineralocorticoid deficiency. Low or normal BP, you have to do for plasma bicarbonate concentration. If it is low, renal tubular acidosis, high, we'll see in GI loss, diuretic use, magnesium deficiency, Bartter, and Gieselman syndrome. So coming to management, have to concentrate how to reduce the potassium losses. So reduction of the potassium losses and replenishment of potassium stores. So how to reduce the potassium losses? Discontinue diuretics or laxatives, treat diarrhea and vomiting, use potassium sparing diuretics like spironolactone or amloride. So replenishment of potassium stores. In case of mild to moderate, that when the serum potassium level is 2.5 to 3.5 milliequivalents per liter, or in asymptomatic neonates, oral therapy is preferred. Dose is 0.5 to 2 milliequivalents per kg of KCl per oral every 12th hourly. Pot chlor is available, which is 20 ml is equal to 15 milliequivalents, or Kesol 5 ml equal to 13 milliequivalents. How to give? Usually pot chlor is given after feeds. In pediatric cases, we usually mix with water, 100 to 200 ml of water, and then we give pot chlor after feeds. In neonates also, it can be given after feeds, but better to divide into small aliquots and to be given through each feed. So what to do if potassium is less than 2.5 or symptomatic, that is in severe cases, patient with GI complications who cannot tolerate oral salts, because oral salts cause GI irritation. So IV therapy is preferred. You can start from 20 milliequivalents per liter up to 40 milliequivalents per liter, which can be given through peripheral line. In case of profound hypokalemia, where the serum potassium is less than 1.5 milliequivalents per liter, KCl should be diluted in normal saline and should be given carefully in a doses up to 0.5 to 1 milliequivalents per kg over 1 to 2 hours. So what to monitor? While in case of severe and profound hypokalemia, continuous ECG monitoring is a must for arrhythmias and frequent testing. For mild to moderate cases, a daily checking of for potassium levels is enough. In case of profound hypokalemia, at least 1 to 2 hours once, potassium levels should be checked. Higher concentration, that is 60 to 80 milliequivalents per liter, should be given through central line to prevent thrombophlebitis. Kindly note, potassium salts should not be diluted in dextrose containing solutions as it provides insulin secretion and cellular potassium uptake, lowering the plasma potassium even further. In treating resistant hypocalcemia, always think of hypomagnesemia. Once you find a serum potassium levels of less than 2.5, inevitably you should send serum magnesium levels. So, in case of resistant, ideally initially give 4 ml of 50% max sulfate in 10 ml of 0.9% normal saline over 20 minutes and then treat hypokalemia. So coming to algorithm approach, if serum potassium is less than 3.5 milliequivalents, that is mild to moderate, 2.5 to 3.5 with normal GIT. So oral potassium chloride 0.5 to 2 milliequivalents per kg per day. If it is less than 2.5 or abnormal GIT, and ECG to monitoring should be done. If ECG is abnormal, then KCl 0.5 to 1 milliequivalent per kg in 0.9 normal saline IV over 1 hour with ECG monitoring. If ECG is normal and serum potassium is less than 1.5, it is KCl again. And if it is normal and potassium is more than 1.5, KCl 40 milliequivalents per liter to IV fluid. If not maintaining, KCl 60 to 80 milliequivalents per liter to IV fluids through central line with continuous ECG monitoring. So coming to hyperkalemia, it is defined in term neonates where potassium is more than 6 milliequivalents per liter, in preterm more than 6.5 milliequivalents per liter, in extremely preterm up to 6.7 milliequivalents per liter. So hyperkalemia is a life-threatening as it can cause cardiac arrhythmias. So what are the causes for hyperkalemia in neonates? First of all, the most common cause what we encounter in NICU is pseudohyperkalemia because of the difficulty in sampling. So heel stick, fingertip sampling, prolonged tonic, even storage of blood also. And in redistribution, that is internal shift, acidosis, non-oliguric hyperkalemia, increased potassium load in diet, blood transfusion, hemorrhage, hemolysis, tissue necrosis, decreased renal excretion in AKI and CKD, aldosterone deficiency or resistance, RTA type 4, urinary obstruction, drugs like spironolactone, amiloride, trimethoprim. What are the clinical features? Muscle weakness, hypotension, diarrhea, oliguria, EKG changes, dysrhythmias, severe dehydration, and virilization. So there's something called non-oliguric hyperkalemia in the neonate. Especially it is seen in very low birth weight babies or less than 32 weeks post-menstrual age, that is within 72 hours of life. Serum potassium can be more than 6.5 milliequivalents per liter in these neonates with normal renal function for age. So its pathophysiology is not completely understood. It may be due to immaturity of the mechanism that regulate internal distribution of the potassium. So what are the investigation? At most we have to rule out pseudohypokalemia. So better to do a second sample of serum potassium. First line investigations, serum electrolyte, serum 1 and creatinine, urine analysis, ECG, TTK, ABG, CBC. In suspicion of adrenal etiology, aldosterone, cortisol, and renin should be sent. This is the ECG changes in hyperkalemia. I put a normokalemic ECG. In hyperkalemia, there will be white flat fever, prolonged PR interval, widened QRS segment, and depressed ST segment, and tall T peak waves. Early change, what you see if potassium is more than 6.5 milliequivalents is tall peak T waves and widening of QRS. When the serum potassium is more than 8 milliequivalents per liter, shortened QT, prolonged PR interval, and further widening of QRS. Where potassium is more than 9 milliequivalents per liter, you'll see absent PVs, ventricular arrhythmias, sine wave, and cardiac arrest. So you have to remember what you see the earliest most is the tall peak TVS, which is the first sign, which is the early sign what you see on an ECG. And the QRS will further widen as the serum potassium increases. When serum potassium is more than 9, most of you see is arrhythmias and cardiac arrest. So coming to transtubular potassium gradient, what it is? It is an index of potassium secretory activity in the distal tubule. It is only valid when urine osmolality is more than 300 and urine sodium more than 25 millimole per liter. It's most useful in distinguishing between mineralocorticoid deficiency versus mineralocorticoid resistance. TTKG is calculated by urine potassium into serum osmolality divided by serum potassium into urine osmolality. So TTKG is expected to be high in hyperkalemia when renal response is intact. Following administration of mineralocorticoid, TTKG is increased in mineralocorticoid deficient but not aldosterone resistant cases, and inappropriately low TTKG in a hyperkalemic patient suggests hypoaldosteronism or a renal tubule defect. It is unreliable in preterm infants secondary to aldosterone resistance and low tubular potassium excretion. So you can't use TTKG in a preterm neonate. So coming to the algorithm approach, for a term, if potassium is more than 6 and more than 6.5 in a preterm, you have to do GFR. We use Short's formula for the calculation of the GFR. If GFR is less than 15 and decreased renal potassium excretion, it's commonly seen in renal failure and drugs, and increased potassium load in blood transfusion, hemolysis, and supplementation. If GFR is more than 15, aldosterone low, renin low, is seen in hyporenemic hypoaldosteronism, that is interstitial nephritis, drugs like NSAIDs, beta blockers, obstructive uropathy. Aldosterone low, high or normal renin is used in primary hypoaldosteronism, congenital adrenal hyperplasia or hypoplasia, drugs like AC inhibitors and angiotensin receptor antagonists. Aldosterone high, it's seen in post-renal transplant, obstructive uropathy, and RTA type 4. So how to manage? This is discontinue any IV potassium containing fluids or drugs that cause hyperkalemia. So the three primary goals. Goal 1, it's always to stabilize the myocardium. Goal 2, to shift the potassium into the cells. Goal 3, to increase potassium excretion. So if serum potassium levels are more than 6.5 millipore per liter, confirm whether true potassium levels by repeating urgent venous or arterial sample and start ECG monitoring. So assess risk of arrhythmias. So look for ECG changes. Look why the rapid rise of potassium to 6.5 millimoles per liter. Look for acidosis or any known hypocalcemia or hypomagnesemia. Stop all potassium drugs. Consider stopping all potassium containing fluids. Look for oliguria, renal failure, and cardiac disease. Avoid use of suxamethonium. Review potentially nephrotoxic drugs. If serum potassium is 6.5 to 7 millimoles per liter, observe for ECG changes. Repeat electrolytes after 2 to 4 hours. If serum potassium level is 7 millimole per liter, observe for ECG changes. Inform duty consultant as treatment may be needed. Symptomatic with ECG changes, always take a print and save the rhythm. In case of where serum potassium is 6.5 to 7, the baseline investigation of electrolyte should be done, that is calcium, magnesium, chloride, bicarbonate, glucose, along with potassium. And observe for the ECG changes if the serum potassium level is more than 7, that to look for peak T waves, prolonged PR interval, reduced P waves, widening QRS, absent P waves, bundle branch block, or ventricular fibrillations or asystole. What to do? Goal 1 is always to stabilize the myocardium. 10% calcium gluconate should be given carefully at 1 to 2 ml per kg slowly over 0.5 to 1 hour. So the response will be seen very early, that is within 5 to 10 minutes. If there is no response within 30 minutes, a second dose of calcium gluconate can be given. Ensure ECG monitoring is in place. How does the calcium gluconate act? Calcium binds to calcium calmodulin receptor and protein kinase 2 on a cardiomyocyte, and it will stimulate the voltage gated sodium channels. So sodium will enter into the cell and it will cause dV by dt, that is for the action potential phase 0. There has been studies which have been done by using hypertonic sodium in case of where they can't use calcium, in case of digitalis toxicity, and in hypercalcemia where calcium gluconate cannot be used. In such studies, hypertonic sodium in the form of sodium chloride or sodium bicarbonate has increased the extracellular sodium, which has in turn stimulated the voltage gated sodium channels and caused membrane stabilization. So in case where pH is less than 7.2 and bicarb is less than 14, a soda bicarb can be used 1 to 2 milliequivalents per kg per hour IV. Make sure that sodium bicarbonate and calcium gluconate should not be given through the same IV line, as there is a risk of precipitation. Second goal is like, what are the drugs which will shift the potassium inside the cell? It is IV salbutamol. It bolus 4 micrograms per kg or 5 minutes. Nebulized albuterol 400 microgram. The dose can be repeated after 2 hours. Next is glucose insulin administration. Therapy may begin with a bolus of insulin and glucose, 0.05 units per kg of human regular insulin with 2 ml per kg of 10% dextrose, followed by 10D 2 to 4 ml per kg per hour, and human regular insulin, that is 10 units per 100 ml at 1 ml per kg per hour. Always monitor for glucose, that is for hyperglycemia, every 30 minutes for initial 2 hours. The third goal is removal of excess potassium, where you can use IV furosemide 1 milligram per kg, but cannot be used in oliguric AKI. Rectal administration of caxilide, which are resins, 1 gram per kg at 0.5 gram per ml of normal saline with minimal retention time of 30 minutes. The dose can be repeated 6 to 8 hourly if needed. You can't use it in a preterm neonate because there will be hypomotility of the gut and the risk of NEC will be more. While using resins, colon should be irrigated after 6 to 12 hours and before any further dose given. In case of persistent refractory hyperkalemia, we can consider exchange transfusion, that is double volume exchange transfusion, where you have to use the fresh blood should be used, that is which is within 24 hours, and peritoneal dialysis, which has a major role in infants less than 1 kg, and renal replacement therapy, other than that hemodialysis and hemofiltration. So how does this beta adrenergic, insulin, and soda bicarb act? Beta adrenergic will bind to beta receptors and insulin to the insulin receptor, and sodium bicarbonate will exchange sodium for the hydrogen. All this together will stimulate the sodium potassium ATPase, which cause intracellular shift of potassium. So coming to the left hand side, so whatever you see on the red is the cell membrane stabilization. So first and foremost, you have to stabilize by using the calcium gluconate, and then potassium intracellular transfer, where you use the beta adrenergic, insulin, and sodium bicarbonate. And coming to the green one, where potassium renal excretion, where you can use furosemide, you can use resins and dialysis. So what are the key summary points? Neonates are in a net positive potassium balance. Although this balance is appropriate for somatic growth, it places the infant at high risk for life-threatening hyperkalemia. The positive potassium balance is the result of increased intestinal absorption of potassium and decreased renal excretion. Infants born at less than 32 weeks of postmenstrual age should be monitored for hyperkalemia during the first 72 hours of life. When treating hyperkalemia in the neonate, resin should be used very cautiously due to the risk of serious complications such as intestinal obstruction and perforation. Thank you.
ಚೆನ್ನಾಗಿತ್ತು ಮೇಡಮ್, ಸೂಪರ್.
Thank you, Dr. Girija. We'll move on to the next session.
Very nice.
Sharing the slide, Dr. Girija. Yeah. Dr. Jagadeesh.
Oh.
Yeah, Dr. Jagadeesh.
Yeah, I can hear you.
Yes. You can start your presentation.
Yeah, but
Dr. Girija,
I
stop
think she has
sharing
to.
the slide, or you can just directly share. It will change. Yeah. Now you start sharing, Dr. Jagadeesh. Thank you very much, Dr. Girija. It was wonderful, a brief and a very comprehensive presentation. You will have a lot of questions already. The participants are posting the question. We'll take up after the session of Dr. Jagadeesh. And today's session will be moderated by Ajay. Ajay is also ready with the questions. Okay, over to you, Dr. Jagadeesh. Please start the session.
Good evening. I thank NNF Karnataka and all the members for giving us an opportunity to speak on the common topic which we regularly see in our NICU. And one such topic is hypocalcemia, and of course, the metabolic bone disease of prematurity. So what I would do in the next half an hour or so, they are vast topics. I would like to give a kind of overview for all mostly the postgraduates or the residents who are actually will help you all to approach both these case scenarios and try to manage them at the best. So looking at the approach, I think any topic, what I would approach any topic as, when would I suspect such hypocalcemia? Why should I have hypocalcemia? How do I approach and how to manage? And what is the objective evidence in terms of the recent studies, or what is the protocol, so that I can, so any topic I think the residents should approach in this form, like the when, how, and what is the objective evidence. That is the WHO approach. Now let's look at what calcium does. Now calcium, you know that 99% of the calcium is in the bone, 1% is in the extracellular fluid and the ICF, and you know it performs innumerous functions like blood clotting, excitability of the nerve and muscles, metabolic regulation of the action of the hormones and enzyme action. And therefore, you have to think calcium when you have a mnemonic called CATS. That means whenever you have dealing with seizures or convulsions, you're having electrolyte abnormality induced arrhythmias, as you can see, like the prolonged QT interval or QRS abnormalities, tachycardia. Some children will present with cyanosis. So you can have tetany, of course. Neonatally, you cannot well identify the Chostek's and the Trousseau's sign. Whenever a child presents to you with stridor and spasms, you are going to think of calcium. Sometimes the specific could be very non-specific, like vomiting, irritability, abdominal distension, increased tremulousness, jitteriness. So there could be a wide variety or a wide spectrum of calcium disorders. But I think from today, you would think at least cats when you have hypocalcemia in picture. So let's see, when do I consider hypocalcemia? What are the levels when I measure? All of us know that ionized calcium is around 50%. The remaining 50% is bound to albumin. So ideally, ionized calcium is what we are going to determine because it's of physiological significance. That is what is going to carry out your action. So most of it is defined by ionized levels. So as in a preterm, you can see less than 4 milligram per DL, you consider it as hypocalcemia. In a term, it is a little more, 4.4 as hypocalcemia. In older children, 4.6 milligrams per DL. A word of caution, when you're applying total calcium, you always look at, are you dealing with a hypoalbuminemia condition, or are you dealing some conditions associated with alkalosis, which increase the protein binding to albumin? As a result, you're going to have hypocalcemia. So hypocalcemia, you're going to look at when you think of cats. When you're looking at criteria, you're looking at a calcium ionized level, which is less than 4. Now, to understand the causes of hypocalcemia, I think next few slides, I would just go on to, before I enumerate the causes, I think if you understand the physiology, the pathophysiology, both fetal as well as calcium homeostasis, it will very well help you to identify the causes of hypocalcemia. And I don't think you need to mug up the causes. Now let us look at what happens in the fetus. All of us know that the fetal skeleton is dependent upon sufficient maternal supply of calcium. And there is an active transfer of calcium from the mother. There's production of PTH-related peptide by the placenta and other fetal structures. And it acts on unique placental receptors which regulate the fetal calcium transfer. Now, what happens after birth? What are the changes which are going to happen in the calcium metabolism? Maternal calcium, once after delivery, is interrupted. The PTH-related peptide synthesis diminished, and there's going to be a rapid fall of your calcium concentration in the next first 24 to 48 hours. And PTH and calcitriol will increase later by 3 to 4 days of life. So you have a window period where you're going to have a fall of your calcium concentration in the first 24 to 48 hours, and where our neonates are going to be prone to early onset hypocalcemia. Though the neonate will adapt in the next few days by increased responsiveness to renal tubular PTH increases, it will take some time for him to bring up, then PTH itself will rise after around 48 to 72 hours, and therefore the decrease or the physiological fall of calcium is the reason for the most important first part of today's talk, that is early onset hypocalcemia. Now, before we go into the other, just look at causes of early onset hypocalcemia. I told you that it is because of increased reduction in the serum calcium that physiologically occurs in the first 3 days in newborns, and a delayed PTH response in response to your hypocalcemia. Therefore, can you guess where it can be exaggerated, where there will be an exaggerated physiological fall? Yes, in term infants, anybody who's having a delayed transition, like for example, you can see birth, or you're going to see infant of diabetic mother, or when the placenta is unhealthy, like for example, you have growth restriction. And if you to summarize, what are the causes of early onset hypocalcemia? You could see that prematurity, anything which causes an exaggerated fall of your calcium, and delayed PTH surge is going to be the causes of early onset hypocalcemia. You could see that prematurity, infant of diabetic mother. This is just to sum up the causes: perinatal stress or asphyxia, intrauterine growth retardation, if the mother is on anticonvulsants, which can block the vitamin D metabolism, phenobarbital, severe vitamin D deficiency in the mother could also be the causes of early onset calcemia. Now, to just look at in a preterm, there'll be exaggerated fall of calcium. There will be decreased response to their target organs, increased calcitonin, which will add on to the reason why preterms are more prone. And if you see birth asphyxia, it's mainly due to increased phosphate load and increased calcitonin production, renal failure, and decreased PTH response. Whereas if you see in infant of diabetic mother, it's mainly hypomagnesemia is playing a part, which is causing red. So I think it is clear. We divide hypocalcemia into early onset hypocalcemia, which presents early within the first 72 hours, and late hypocalcemia, which we see after 72 hours, which will go in the next few slides. But just to understand, it is mainly due to decreased, exaggerated fall and contributed by a delayed PTH rise. And these are the causes of early onset hypocalcemia. And therefore, we derive that we are going to monitor these high-risk infants, especially those who are preterm, the infant of diabetic mother, breast asphyxia, IUGR babies. So you're going to monitor them probably at 12 to 24 hours interval. For the first 24, 48 hours, you're going to supplement them with calcium. And early onset hypocalcemia is mostly going to be asymptomatic. Most of the early onset hypocalcemia is going to be asymptomatic. Now, let's look at, to understand the causes of late onset hypocalcemia, we need to go further into the calcium homeostasis. And at the end of this, you would easily get a good approach to how to apply this into the causes of, so whenever there's a late onset hypocalcemia, obviously it is dealing with something more serious than the normal physiological fall. So therefore, let us look in the next few slides what are the causes of late onset hypocalcemia? Before that, let's understand the physiology of vitamin D metabolism. You know that the calcium level in the blood is going to be maintained by three key players. And the three key players are the calcium sensing receptor, the parathyroid hormone, and vitamin D. So if you're going to have hypocalcemia, so either you should have a disorder of the calcium sensing receptor, or you're going to have a disorder of parathyroid hormone, or you're going to it's a disorder associated with vitamin D. Now, just let us quickly look at what's the PTH. So it's an interaction of the organ between the parathyroid, bone, kidney, and intestine. So you have the PTH, which is going to act upon the bone, the kidney, and intestine indirectly through vitamin D. Now, what does PTH do? Now, PTH is going to normalize your hypo. It's going to sense the hypo. How is it going to sense? It's going to sense by the calcium sensing receptor. Now, the calcium sensing receptor, whenever the ionic calcium are less in the blood, it's going to activate the calcium sensing receptor, and it is going to cause PTH release. So if the ionic calcium levels are normal, then you're going to block the PTH release. So therefore, whenever there is hypocalcemia, not enough to stimulate PTH release, so you're going to have PTH which is going to be produced, and PTH in turn is going to cause three things. It's going to act on the bone, it's going to stimulate the osteoblasts, which are going to cause release of calcium from the osteocyte membrane, from the bone fluid into the extracellular fluid, which you can see here. So you can see that it's activated by PTH. So one of the important action of PTH is resorption of calcium from the bone so that you get a normal calcium level in the serum. So it does it by stimulating the osteoclast differentiation. So one action, very important, is PTH on the bone is going to cause action on the bone, which is going to release calcium. So it's going to release calcium from the bone and therefore normalize calcium. 1 point. Second, on the kidney, very important. Unless you understand this, you will not understand the causes of hypocalcemia. So if PTH, so what does it have on the kidney? Very important. It's going to cause increased calcium resorption. So it's going to cause calcium absorption, and it is going to cause phosphate excretion. So it's going to cause phosphate excretion and calcium absorption. And therefore, if you're having a PTH problem, what are we going to get? If you're going to get if the PTH is not acting, if the PTH is not there, obviously, you know that phosphate levels in the blood will be high because it's not getting excreted in the urine, and you're going to get hypocalcemia because it's not going to get absorbed in the kidney. So that's how PTH is going to act. So PTH is a phosphaturic hormone. It helps the absorption of calcium, excretion of phosphorus. On the GIT tract, it doesn't act directly through the calcitriol because PTH, it activates the conversion of 25-hydroxy to 125-hydroxy and therefore to active form of vitamin D, which in turn absorbs calcium from the intestine. Now, what is the calcium sensing receptor? Now, calcium sensing receptor is extremely sensitive to your small changes in the ionized calcium. And I told you that it senses the calcium. If calcium levels are normal, it blocks the PTH secretion and also acts on the kidneys to increase the urinary calcium. So what happens if you have a calcium sensing receptor mutation? If you're having a calcium sensor receptor mutation, you're going to have decreased PTH, and you're going to have increased urinary calcium despite hypocalcemia. And that's one of the causes which you're going to look at as a cause for as a cause for your hypocalcemia. So it could be a mutation in the calcium sensing receptor. And last, so you could see that it increases the PTH. It looks at the kidneys. It's going to cause increased excretion of your calcium, blocks the PTH, and therefore if there's a mutation of the calcium sensing receptor, you're going to have increased calcium, that is hypercalciuria, with PTH despite your low hypocalcemia, despite low calcium. Now, next important player is vitamin D, and all of us know that vitamin potentiates the action of PTH and on increasing the calcium absorption in the kidneys, and a major determinant of calcium resorption in the intestine. Whereas in the bone, it stimulates osteoblast production. And most important is another two players are also there, that is magnesium and phosphate. Now, you know that magnesium levels, so magnesium can act on the PTH. That means it can either inhibit the PTH secretion or block its action. So hypocalcemia, so hypomagnesemia, when you're going to have decreased PTH, and therefore you're going to have something which is not responding to calcium, IV calcium. Please think of magnesium. And how does magnesium act? It acts by blocking the PTH secretion or action. Okay, now let's look at, I've already covered this. So just to understand, I pressed something, so I've got a wrong thing. So when I look at next determinant, so we finished with how PTH plays a part, how vitamin D plays a part, how magnesium levels play a part, and how your calcium sensing receptor play a part. Now let's look at the other electrolyte. The other electrolyte is phosphorus levels in the blood. Though it is not important for us to look at the regulation of calcium, but it's very important for us to evaluate the cause of hypocalcemia. And it's a major role in assessment of the cause of hypocalcemia. Now, as I told you, PTH has a phosphaturic action. And therefore, whenever you have hypocalcemia, what do you expect? You expect rebound increase in the PTH, and therefore you're going to have increased phosphate excretion, and therefore you're going to have low phosphorus. So whenever you're having a low phosphorus, you're always expecting an increased PTH action. Okay, so when you have increased phosphorus in a hypocalcemia condition, then what are you supposed to think? That means PTH is not getting activated, and therefore you're going to think either there is a PTH deficiency or a PTH resistance. And what are the causes of PTH resistance? You have PTH, but it's not acting. So end organ reservoir, so like pseudo hypoparathyroidism, or it could be because of renal failure. So so how do I approach hypocalcemia? So hypocalcemia, especially the late onset causes, could be because of either of increased chelation, or they could be because of a decreased total calcium. Now, what are the causes of increased chelation? Is when I have a high phosphate load. So high phosphate load bind to calcium, hypocalcemia. So high phosphate load, what are the situations? Formula feeds, cow's milk, or when you have hemolysis, when you have cell lysis. So the first step in evaluating the hypocalcemia is to look for, am I having a high phosphate load? Is there a history of cow's milk? Is there a history of formula feeds? Is there a history suggestive of hemolysis? So then I look at conditions dealing with increased chelation. So then it could be because of a decreased total calcium, which could be either vitamin D related or PTH related. Now, how do I go further? Now, suppose if it's vitamin D related, it can be either because of a deficiency or because of a resistance. So you know that whenever there's vitamin, either it is because of vitamin D deficiency or resistance. So what is the end result? You're going to get is in a low or a normal phosphorus. So whenever you have a low or normal phosphorus, think of vitamin D deficiency related or vitamin D resistance related conditions. So when you have a condition of high phosphorus, you in the setup of hypocalcemia, think that PTH is deficient, or you look at low magnesium levels, or there is PTH resistance in terms of pseudo hypoparathyroidism or renal failure. So now how do I approach hypocalcemia? First, I exclude phosphorus load. Now the phosphorus load, once I load excessive phosphorus, then I take conditions which are going to cause low phosphorus or normal phosphorus or a high phosphorus. Now, what are the conditions? If I have a low phosphorus, I told you that you're dealing with either a vitamin D or a magnesium level. So you're going to look at magnesium levels. If the magnesium levels are normal, you're going to do a 25 hydroxy vitamin D, and 25 hydroxy vitamin D, if it is low, then you know you're dealing with vitamin D deficiency. Now, if the 25 hydroxy vitamin D is normal, then you know you're going to look at a further very rare cause, that is you're going to look at doing an active form of 125 dihydroxy vitamin D, where you're going to think of VDDR, vitamin dependent resistant rickets 1 or 2. Whereas if magnesium is low, you know it is hypomagnesemia. So in a nutshell, if the phosphorus is the important standpoint for assessment. So if you're having low phosphorus, you know that there is a problem in vitamin D, and then you're going to look at vitamin D levels. If the vitamin D levels are low, you're going to think of vitamin D deficiency. If it is normal, you're going to think of a rarer cause, that is calcitriol, you're going to do. And if it is increased, 1. If it is low, you know it is 1. And if it is there but it is resistant, endogenous response is resistance is there, it is VDDR type 2. And of course you're going to look at magnesium levels. When you have low magnesium, you're going to think of hypomagnesemia as a cause. Now let's look at high phosphorus. I told you PTH is a phosphaturic hormone. So when you have hyperphosphatemia, that means increased phosphorus in the condition of hypocalcemia, you have to look at PTH, either PTH low, that means hypoparathyroidism, or you're going to look at resistance. So you start off with looking at resistance. That means you'll do a serum creatinine. If the serum creatinine is normal, then you're going to look at PTH. And I told you high phosphorus means PTH is not acting, and therefore if the PTH is low, you're going to think of hypoparathyroidism. If the PTH is high, you're going to think of pseudo hypoparathyroidism. Whereas if the PTH is normal, that means you're having probably a calcium sensor receptor mutation. So you're going to think of a familial hypercalciuric hypocalcemia, where you're going to have increased calcium excretion. You're going to have an increased calcium urinary excretion. So this is how you're going to approach hypocalcemia with the underlying physiology. Now let's look at what are the causes. Now let us summarize. What are the late causes of late onset hypocalcemia? So late onset hypocalcemia could be because of a high phosphate load, which I told you. Second, it could be because of magnesium levels, so low magnesium. And I told you how magnesium acts on PTH to block its action on secretion. Vitamin D deficiency itself, PTH resistance or decreased production, that is hypoparathyroidism, or it could be some iatrogenic cause. Now let us look at hypoparathyroidism. Now hypoparathyroidism, you can have either a primary hypoparathyroidism or a secondary hypoparathyroidism. Primary hypothyroidism means when there's isolated parathyroid hormone is not getting produced, or it could be because of a calcium sensing receptor inactivating mutation, which I explained already, or you can have some syndromic hypoparathyroidisms, which we'll see in the next few slides. Or it could be secondary when you have maternal hypoparathyroidism, so increased maternal parathyroid hormones causing hypoparathyroidism in the neonate. So it could be secondary cause. Now, among the syndromic causes, we have DiGeorge syndrome, the catch-22.
Dr. Jagadeesh. I think we have lost Dr. Jagadeesh. Dr. Jagadeesh. Yeah. Jagdish, we just lost you. Can you re-log in? Yeah, I mean, not re-log in, just
Prashant. Prashant,
yeah.
call him
Ajay,
on the
ಹೇಳಿ.
mobile.
Yeah, I've called him. I've called him. Kushar sir, Raj sir, here. Call Madin. He's logging in.
Sorry.
Jagdish.
Meanwhile, you can take questions for Girija, Prashant.
Yes, sir. Dr. Ajay,
Yeah, I'm here, Prashant.
you can start.
Dr. Girija?
Yeah.
Dr. Girija, are you there? Dr. Girija, you can unmute Dr. Girija.
Yeah. Dr. Girija is online. Yeah. Yes, you can ask her the question.
Yeah, Dr. Girija, it was an excellent presentation. Fantastic. You did it very well, and it was very comprehensive. There are few questions regarding the hypokalemia and hyperkalemia. And regarding hypokalemia, one of the questions which was asked in the chat box was about how exactly you go about with hypokalemia.
Ajay,
Able to hear? Yeah. Now, what about? How about it now? Is it okay now? Am I audible now?
Little more louder. Please talk loud.
Okay. Is it okay now?
Better if you can.
Okay,
Ajay,
fine.
if you are using a computer,
Yeah.
Ajay, if you are using a computer, please come closer to the computer. That's all.
No, I'm using the earphones.
Headphones may not be ideal. Okay.
Okay. Girija, one of the questions I asked regarding hypokalemia.
Sir, can you be a little bit audible, sir?
Oh, you. Okay. I'll try. How about now?
Sir, little bit more if you don't mind.
Ajay, take off the headphones and use the speaker.
Yeah, I'm trying to use the speaker. Okay, remove the headphones. What about now? So, am I audible now?
It's definitely
yes, sir,
better.
I'll try.
Okay. Sorry. So sorry. This is regarding hypokalemia. One of the questions was how exactly to go about hypokalemia. Is there any formula? Do you treat over a period of time? And what do you make? Any changes in the maintenance fluid?
So there is no change in the maintenance fluid, and when it comes, there is no formula for the hypokalemia. It is like to treat for the mild to moderate. We usually add for the IV fluids potassium chloride. It comes as 15% in 10 ml. That is 1 ml is equal to 2 milliequivalents. You can start as less as 20 milliequivalents per liter. And based on the response, you're going to do every day the serum potassium levels, and based on the response, we can add or we can decrease and we can change.
What about for a very low level of potassium, say a 1? Do you give anything, some sort of a push over a period of 1 hour?
Yes, sir,
Potassium
we
or
give
something?
KCL,
Okay.
0.5 to 1, 1 to 2 ml per kg mixed with the 0.9 per normal saline over 1 hour.
Okay. And
So
sticking.
can you be audible, sir? I'm really
Yeah.
not able to hear you.
Yeah,
Dr.
this is
Jagadeesh,
regarding birth asphyxia. Say, supposing you start maintenance potassium on day 3. Do you look at the urine output or do you check the serum potassium and the renal status?
Sir,
This is regarding the 1 minute.
Yeah, Dr. Ajay, Dr. Jagadeesh has come back. We'll just go ahead with the presentation and then we'll continue questions later. Is it
Sure.
fine?
Yeah, fine.
Dr. Jagadeesh, please
Yeah.
put in slideshow mode and you start from the previous slide. Yeah. Yes, catch 22. Yeah, from there you can start. Yeah.
Okay. So fine. Sorry for the inconvenience. So I was telling you all about that when we are looking at late onset causes. So when you're looking at some hypoparathyroidism, you can have either iatrogenic, or you can have isolated hypoparathyroidism, or it may be associated with some syndromes, and some of the syndromes which I told you earlier. And some of the common syndromes are the catch-22, the DiGeorge syndrome. So whenever you have facial dysmorphism, cardiac anomaly, when X-ray shows absence of thymus, a cleft lip, you think of associated syndromes. So now when we look at some of the other syndromes, like when you have PTH resistance. So PTH resistance, most of the times it is due to, it may be transient in the underlying renal dysplasia or obstructive uropathy, whereas two syndromes which are associated with pseudohyperparathyroidism, which have generalized hormone resistance. So that is your Albright syndrome, that is pseudohyperparathyroidism type 1A, where you have generalized hormone resistance to PTH, short stature, various skeletal anomalies. However, these skeletal anomalies are not usually observed in the neonatal period. And when you have pseudohyperparathyroidism type 1B, which does not have skeletal symptom, but definitely have resistance to PTH. Okay, so some of the other rarer causes of the sometimes common of iatrogenic causes of hypocalcemia are use of citrate blood products, post-exchange transfusion, lipid infusions, bicarbonate therapy, diuretics when you're using furosemide or a phosphate therapy. So these are some of the causes. So if I just look at the summing up these things with the causes of late hypocalcemia. So you just have to look at either we are looking at, so some of the case scenarios we'll just look at so that we identify these disorders. Once we understand the causes, I think the management becomes very easy. So you could see that you have a term neonate who's 3.8 kg with a history of maternal diabetes on insulin, who was jittery, mild respiratory distress was admitted. And if you see that his ionized calcium was 0.78 millimoles and magnesium was also low, 0.49. So you know that this is one of the causes of, so early onset hypocalcemia, you have underlying maternal diabetes. So probably you're dealing with early onset because of exaggerated fall. You have another condition where you have birth asphyxia, 30 hours, who just came to you as subtle seizures. So just don't, it may be because of birth asphyxia itself, but if you do an ionized calcium, you see it's 0.69. So you're going to think of hypocalcemia in this scenario, and you're going to treat the hypocalcemia. Now let's look at another case scenario, which can probably on the late hypocalcemia, a 10-day-old who was breastfed, who had birth weight of 2.6, who presented to us with seizures, laryngospasm, apnea. His septic screen was normal, CSF was normal. So ionized calcium was 3.3, phosphorus was 2.8, alkaline phosphorus was 800. So what do you infer from this? So there's low calcium, low phosphorus, high alkaline phosphatase, probably in the setup of a vitamin D deficiency, and you have a history. So you always ask for a history of whether mother has taken her supplements during pregnancy. Here in this mother had not taken a as a secondary to maternal vitamin E deficiency, baby landed up with hypocalcemia. The fourth case scenario, you're having a term birth with a birth weight of 3 kgs. Ionized calcium was low, phosphorus was normal, PTH also was normal. So what can you think of in this condition? When you have a low hypercalcemia, there was no response to IV calcium, with your PTH being normal, phosphorus being normal, you think of magnesium deficiency. So you look at magnesium deficiency in this condition. Now, let us look at the other two case scenarios, which are again dealing with late onset hypocalcemia. So here you have a 10-day-old with seizures. Ionized calcium was 3.2, phosphorus was low, PTH is again on the lower side, 2.2, and 25-hydroxy is not detected at all. So this case scenario I just put up because to let you know that phosphorus is also low. So whenever you have PTH being low, you may have hyperphosphatemia, where here you are seeing that phosphorus is low. So therefore, probably it is a sampling error. So whenever you have to, so what are the precautions you're going to take while sampling of calcium? Preferably, it should be a non-squeeze sample, and it should be airtight, and it should be processed quite quickly. And even for PTH, you have to take the sample quickly, or you have to keep it in ice, keep it freezed if you're not immediately sampling it. Otherwise, you're going to get not a relevant value of PTH, and you're going to unnecessarily label this person as hypoparathyroidism. So you have to always look at sampling errors. So you have to look at collecting it fresh. Ideally, it should be pre-meal, early morning, because carbohydrate also has effect on phosphorus. So you look at either early morning sample. So you look at when you're sending PTH has to be processed clearly, otherwise you're going to have processing errors. Now, when we look at this another case scenario where you have a 7-day-old seizures presented with seizures, birth weight was good, 3.2 kgs, ionized calcium was low, phosphorus was high, 8.5, creatinine was normal, 0.2, a PTH was inappropriately low. So this is a classic case of hypoparathyroidism where you're having, so how did we approach this case? So just to summarize the whole thing, so whenever I have hypocalcemia, so first investigation, as far as assessment wise is concerned, I'm going to rule out phosphate load. So first assessment is rule out phosphate load. So I'm going to ask for history of either cow's milk, or whether the is on a formula which has high phosphate load, or any evidence of cell hemolysis. So once I rule out high phosphate load, the next investigation I look at is creatinine when a sitting of phosphorus. So if I have a high phosphorus, the next important investigation I look at is creatinine. If the creatinine is normal, the next investigation I look at is PTH. So when PTH is inappropriately low in the setting of high phosphorus, I think of hypoparathyroidism. Okay, so just to go back to the previous thing, so whenever I have a PTH which is low, I'm going to think of hypoparathyroidism. And I told you hypoparathyroidism could be isolated, or it could be syndromic, or it could be secondary. If when you have a PTH which is high, that means there is resistance. So therefore, it could be resistance comes from some syndromes which I told you of pseudo hyperparathyroidism, or it could be if the PTH is normal, either you're having a calcium sensing receptor problem, and therefore you're going to have your look at urinary calcium, and the urinary calcium is high. You look at urinary calcium creat ratio, and then you may suspect a familial hypercalciuric hypercalcemia. So with that, I've completed the causes of hypocalcemia. So it could be early. So when I say early, it is within 72 hours, and the causes are most likely because of a decreased exaggerated fall and a delayed PTH rise. Whereas late onset hypocalcemia, I'm going to think of mainly primary or secondary causes involving the parathyroid, or I'm going to look at magnesium levels, or I'm looking at syndromes, or am I looking at vitamin D deficiency states. So that's how I summarize the causes of early and late onset hypocalcemia. Now, approach wise, you have history, you take a family history, look at maternal details, nutrition supplies in the nutrient, look for signs and symptoms, which I already told. Look at the calcium, magnesium, phosphorus levels. Acid-base status is important because you have alkalosis, which can be associated with hypocalcemia because of increased calcium albumin binding. Chest radiograph, I told you, because of thymic shadow, or look at the conotruncal anomalies. And I've discussed about various electrolytes which you're going to do, genetic studies for syndromic association, and of course, T cell function disorders whenever you're going to think of a thymic hypoplasia. So now, how do I look at management? The management, I said, most of them could be, you divide them either asymptomatic or symptomatic. If it's asymptomatic, you observe them, and still it's quite controversial on whether to treat the asymptomatic, but you know that they can have neurological as well as respiratory and cardiac abnormalities. So you monitor the at-risk babies, give them maintenance calcium. Whereas if you're going to have a symptomatic management, if with seizures or with ECG changes, especially with the ionic calcium, which is less than 3, to give calcium, per kg, followed by a maintenance of 80 mg per kg per day, which is around 8 ml per kg per day, preferably as infusion. And after that, the next day, you reduce the infusion by 75%, and next follow it up by 50% reduction, along with simultaneous addition of oral calcium on day 3, or that means after, on next subsequent day. Once you normalize it, stop the calcium and you start activated vitamin D. Many a times this step is missed. The activated vitamin D is missed. So all of you, we need to start the vitamin D. And calcium, you give a good amount, around 40 to 80 mg per kg per day. Again, controversies on which product. Calcium gluconate is better. Carbonate absorption from because of the pH, high pH in the stomach absorption. Most of the formulas are hyperosmolar. So preferably some literature says calcium gluconate is better. 3 divided doses. And for whenever you have a hypoparathyroid state or a vitamin D deficient state, you know that when you're giving vitamin D, it may not be absorbed. So where you need to give an activated form of vitamin D, that is calcitriol, which has a short half-life, and it bypasses the 1-alpha reductase, 1-alpha renal hydroxylase step, and therefore it acts faster. So you use calcitriol in a dose of 20 to 60 nanograms per kg per day. And vitamin D, in a vitamin D setup, you are going to use around 2000 international units per day. So roughly you can give weekly, or add up the amount, and you're going to give weekly as 1 dose, or you can give daily 2000 international units. Now, whenever you have a setup of hypoparathyroidism, you know that you're also dealing with a high phosphate load. So you have to look at reducing the phosphate load. You avoid calcium phosphate. Try to keep the calcium phosphate product of less than 55. And you don't initially start, you can use calcium supplements to reduce the calcium, to reduce the potassium, the phosphate levels also. Now, once we give these treatment, we also need to monitor the calcium, phosphate, urinary calcium, and the calcium creat ratio, because your aim in most of the cases, except for pseudo-hypoparathyroidism, will be to keep the calcium in the lower range of normal because of a defective distal tubular absorption, which leads to hypercalciuria and nephrocalcinosis. So you're going to keep it in the lower range of normal. Whereas in patients with vitamin D deficiency, which I told you, you may have to give active form as well as 1000 to 2000 international units of vitamin D daily. So so whenever you're looking at acute management, it is IV calcium. And I told you how we are going to taper it and then start off activated vitamin D. Whenever you're thinking of a hypoparathyroid condition, you're going to look at whenever there is a defect in the formation of active form of vitamin D, give active form of vitamin D itself directly in the dose of 20 to 60 nanograms per kg per day, and your activated vitamin D, that is cholecalciferol, and monitor them also, because it can lead to hypercalciuria and nephrocalcinosis. So your aim will be to keep it in the lower range of normal, except in pseudo-hypoparathyroidism, where you're going to keep the levels and the higher range of normal. Now, how long to give? Now, you need to know that in those causes, because of secondary due to maternal hyperparathyroidism, you can give it for 6 weeks and then later stop it. Whereas most of the other causes, especially when you're thinking of a syndromic cause or when you think of hypoparathyroidism, the duration would be much longer. And you're going to monitor, that's what I want to stress, you're going to monitor these levels, not only just start them, you're going to monitor these levels. So whenever you have a setting of a hypomagnesemia, that is, I said, you may have a low calcium, phosphorus is normal, PTH could be normal, and when there's poor response to hypomagnesemia, you're going to give 2 doses of magnesium, 50% magnesium sulfate, 0.2 ml per kg, 12 hours apart, deep intramuscular, followed by maintenance orally for the next 3 days. So when you have a high phosphate load, especially cow's milk, or you're going to stop and advise for exclusive breast milk, or look at a formula which has lower phosphate load and the animal milk is discontinued. So with this, I have given you a kind of approach as well as the causes and also management of hypocalcemia. So if there are any questions, we can take it up at the end. So in brief summary, always think of calcium, especially I told you, when you have symptoms suggestive of CATS, that is convulsions, arrhythmias, tetany, or your laryngospasm, stridor, or you're going to think of sometimes non-specific symptoms. Decide whether it is early onset and late onset. Early onset, I told you, it could be because of exaggerated fall. Many a times it will be asymptomatic, whereas if it is late onset, you're dealing something with either vitamin D, PTH, or you're looking at calcium sensing receptor, or you're looking at magnesium levels, and usually they are symptomatic. And I've given you an approach. You start with phosphate, and if phosphate is high, rule out the phosphate load, rule out renal failure. If phosphate is low, think of vitamin D deficiency states, do the vitamin D. If it is low, it is vitamin D deficiency. If it is normal, you may have to look at looking at activated form of vitamin D, calcitriol levels. And if it is low, you may think of vitamin D dependent rickets, VDDR type. Whereas if the phosphate is high, always think it's a PTH problem, it's hypoparathyroidism, or you're dealing with PTH resistance, that is either renal failure or you're looking at pseudo hypoparathyroidism. And if even in that condition, when you're having an increased PTH, you look at conditions of familial hypocalciuric hypocalcemia. So with this, I have completed hypocalcemia. I hope I've given you a brief overview of hypocalcemia and its management. Now I'll look at going to the next topic. Here, what I'm going to do is I'm going to touch briefly because it's a whole topic by itself. So the next so let's look at the next topic, that is osteopenia of prematurity, or metabolic bone disease of prematurity. Let's look at this case scenario. You have a 26-weeker, 700 grams who had chronic lung disease, 2 weeks on exclusive TPN, enterally fed unfortified EBM. So, of course, now, in this today's scenario, you may not be having somebody who's not fortified, or TPN is also, we're going to start with calcium and phosphorus. So probably this is an older case, and you see that I just want to bring notice that some of the risk factors for osteopenia of prematurity here. So you have a 26-weeker who's an extreme preterm. You have somebody who's having a chronic lung disease, who could be on medications which can affect the calcium and phosphorus. You can have who's been on TPN, and as a result, you see mostly they may not present to you immediately. They present to you later, probably from 6 weeks onwards. So they may come to you with different problems, which we'll see. So here in this case, you saw that the patient had hypocalcemia, phosphorus was quite low, alkaline phosphatase was quite high, X-ray features he's having, you can see these fractures after treatment, probably osteopenia and all is much better. So I just wanted to bring to you to this next case. So with the same case, we was treated on multivitamin supplements of only vitamin D. So repeat biochemistry, the calcium had normalized, phosphorus, but alkaline phosphorus had increased, whereas parathyroid hormone, you could see, is quite high, and 25-hydroxy-D would be almost near normal, 15 nanograms is normal. So what I just wanted to bring you is on the concern of a recent change is that we need to think not only of supplementing them with phosphorus, we have to actually look at whether we are dealing with a calciopenic problem or a phosphatopenic problem, and PTH is important for the screening and management of osteopenia of prematurity. So this, if you look at, I just want to go through the next few slides on telling you what is metabolic bone disease of prematurity, whom do we screen, when do we screen, what do you have for screening, how do we evaluate them, and how do we manage and how do we prevent them, and what are the recent evidence for that. Now coming to what is bone, it is nothing but decreased bone mineral content, which is relative to the expected level of mineralization for the fetus or an infant of the particular gestational age in conjunction with biochemical and or radiological changes. So all of us know that the osteoid is going to be mineralized, in the fetus because of continuous supply of calcium. And you know that any condition which is causing this block of the transfer of calcium into the osteoid, as in terms of premature delivery, or you're having an unhealthy placenta, or you're having conditions of which like your intrauterine growth restriction or other genetic polymorphisms which make this mineralization of the osteoid not possible, and the amount for the growth, the calcium required for the growth is not matched. So therefore, it's principally a result of inadequate calcium and phosphorus intake to meet the bone growth demands. Now, just to have, that proliferation and differentiation of the cartilaginous precursors and progressive ossification is the primary process, and the calcium, 80% of the calcium and phosphorus transfer occurs between 24th week of gestation and term. The calcium of 90 to 150 milligram per kg per day to up to 150 appears at 36 to 38 weeks, and the main regulator is the parathyroid hormone related peptide for the bone mineralization. So whenever you have a condition which blocks this transfer, when you are going to end up in problems with osteopenia of prematurity. Now, what is the disease burden? It's very difficult to assess the incidence because there is still there's a difficulty in telling you what are the levels, what are the because of different groups, age groups are there, and different criteria are there for defining, and therefore we don't have real incidence. Some incidents say it's probably between 16% to 24%. Now, how does it manifest? With poor extrauterine growth, increased ventilative dependency, fractures, and of course in the long term, of course there's still debate on this, whether really the hypocalcemia has a problem and the long-term growth, that is short stature and osteopenia or adulthood. Now, just to have a brief overview of the risk factors, I told you risk prematurity because of decrease in utero calcium and phosphorus secretion can lead to osteopenia of prematurity. Maternal vitamin D deficiency, if the placenta is unhealthy, like for example in IUGR or preeclampsia, again that will affect your transfer of calcium. Whenever you have genetic polymorphisms are also being detected, just like you have osteoporosis in adults. So postnatal factors, whenever you have inadequate supply to meet the growth, like for example, you're giving limited calcium and phosphorus delivery by TPN, delayed or inadequate enteral feeding unfortified human milk, and when you have full fluid restriction, and of course, when you have an underlying vitamin D deficiency, immobility in the neonates, either you sedation, paralysis, sepsis, or neurological disease, and some of the drugs which are going to block this problem, that is diuretics, who are especially the chronic lung disease, as you saw in the case scenario, patients on steroids or caffeine. So these are some of the risk factors which you're going to, so risk factors are important to identify. These risk factors are going to play a role in causing rickets. So you know that all of this will lead to an abnormal calcium phosphorus secretion, and therefore it's going to be would be a cause for our osteopenia of premature. Now, how do we prevent? By fortifying your breast milk or preterm formula, you try to maintain your vitamin D levels of more than 50 nanomoles per liter with additional vitamin D supplements. Ensure optimal enteral and parenteral calcium and phosphorus ratios. We'll see some of the protocols. So let's see whom to screen. So you know that I've told you who are the risk factors. So all those need to be screened. So premature, low birth weight, those who are on prolonged TPN, those who are on medications like glucocorticoids, loop diuretics, antacids, and those who cannot take in orally, you have absorption problem like necrotizing enterocolon, prolonged TPN. So as such, you know that all preterms you're going to screen less than 32 weeks as our unit protocol, less than 28 weeks, less than 1,500 low birth weight babies, those who are on parenteral nutrition for more than 2 weeks, anyone on medications and chronic lung disease, and necrotizing enterocolitis. Alkaline phosphatase, phosphate levels, and calcium. And one introduction is always think of doing a plasma PTH, which will tell us, which will help us in the clue towards are we dealing with a condition with a low PTH or raised PTH, which will help you in the adequate and a proper management of osteopenia of prematurity. We'll see how. Now, what are the screening tests we have? Now, like alkaline phosphatase, you know that a level of more than 800 or more than 600, which is going up. But again, you have problems in the levels. That means which could be elevated in other conditions. It would be non-specific. Phosphorus levels, again, low values corroborate with your metabolic bone disease. You look at tubular excretion of phosphate, calcium creat ratio. You look at vitamin D levels, and additional whenever you want, you may have to do other investigations like X-ray and the DEXA. Now, what about alkaline phosphatase? Alkaline phosphatase, per se, if you take alkaline phosphate, has a 88% sensitivity and 71% specificity, whereas if you combine it with phosphorus, it has almost 100% sensitivity and 70% specificity. Now, what is the role of PTH in screening? PTH has a sensitivity per se versus alkaline phosphate 71% sensitivity and 88% specificity. Along with serum phosphorus, you have 100% sensitivity and 94% specificity. So you would look at doing a low mellowing of phosphorus, calcium, and PTH level, which increases your sensitivity and specificity. Now you could look at tubular resorption of phosphate. We will see when this will help in the next flowchart, but this is just to tell you about what are the tests you have. Tubular resorption of phosphate, you're going to look at only in conditions which are not responding to your maximal dose of calcium phosphorus and the particular ratios which you're going to give. If it doesn't respond, then you're going to think of these conditions. So you know that tubular resorption of phosphate is at about 75% to 95% is normal. So when you have a high tubular resorption of phosphate, you look at low, it means you have low urinary phosphate. So are you leading with a phosphorus deficiency state? When you're having a low tubular resorption of phosphate, you're looking at high urinary phosphorus wasting. So you're looking at conditions where you're having high PTH levels with subclinical hypocalcemia. Role of X-ray, it is not reliable in early stages. Changes are visible only after 30 to 40% bone resorption. You have various degrees of X-ray. You can see that they have osteopenia, you can have decreased cortical thickness, and also you're thinking of a periosteal reaction. So these are things which you're going to look at on the X-ray, but as we said, that it is usually visible only after 30 to 40% of the bone mineralization. You have role of ultrasound. It can be done precisely in neonates, including extreme preterms. It's not site specific. It correlates with bone mineral content. There's no difference in the trends between available devices, but utility has to be tested in clinical practice recommendations. You're going to actually see that these are the peaks which are observed in a term baby and a preterm baby. So that's how you can use ultrasound in detection of osteopenia of prematurity. Now let's look at what is the screening protocol. So as I said, you look at serum, calcium, phosphorus, alkaline phosphatase. If it is normal, so when do you start screening? You start screening by around 2 to 3 weeks, and you repeat it weekly 1 to 2 weeks later, depending on the risk factors. Now, you're going to do a calcium, phosphorus, alkaline phosphatase. You repeat weekly till term. If it is abnormal, then you're going to think of further investigations like PTH or a tubular resorption of phosphate or vitamin D. If any of these are abnormal, you're going to, after advising for the calcium phosphate, which we'll see in the management, you may have to, if the patient is not responding, again, you may have to look at advanced investigations like PTH, tubular resorption of phosphate and vitamin D, which will help you to, as I said, after 3 weeks, the rationale is it's a time taken for optimizing your enteral nutrition and calcium phosphorus supplementation. You can repeat it 1 to 2 weekly, depending on the risk. Now, just to bring you to the concept that vitamin D or calcium deficiency, you know that we discussed that which will result in a decreased ionized calcium, which in fact will cause increased PTH secretion. And PTH secretion, you know that PTH is going to cause bone resorption, and therefore it mobilizes the calcium and phosphorus, causing osteopenia. So initially, you know, the calcium levels will be normalized. So therefore, calcium will be normal. But what happens is because of the PTH action on the renal system, you have increased phosphate excretion, whereas you don't have normalization of phosphate. You don't have normalization of phosphate, and therefore the low phosphorus is the one which is causing your rickets. And PTH secondarily will act upon the bone, and therefore it worsens the problems of osteopenia. So by just supplementing, now in this slide, I just wanted to tell you that by just plainly supplementing only phosphate supplements without really understanding, am I dealing with an increased PTH or a decreased PTH? What's going to happen is, if I'm going to supplement only with phosphorus, then it's going to bind with the ionized calcium. As a result, it's going to cause further reduction of calcium and cause increased PTH secretion. So therefore, you have to look at, am I dealing with a calcium problem, calciopenic or phosphatopenic, based on the PTH levels, and then you see which patient requires what, which we'll see in the next few slides. So basically, whenever we're having decreased secretion, decreased calcium, as a result of increased PTH, you're having bone resorption, which mobilizes the calcium and phosphorus to the ECF, whereas PTH also causes phosphate excretion. So decreased phosphate has a major role to play in the pathophysiology of rickets, of the osteopenia of prematurity. But caution is, only supplementing phosphate supplements will not help. So you may have to also look at what is the cause for it. Am I dealing with raised PTH cause or decreased PTH cause, and supplement whether you're going to give calcium alone. So that's why in our case scenario, you saw that he was only given calcium, he was only given phosphorus supplements. Therefore, patient did not improve. So we will see in the next few slides how. See, low serum phosphate concentration will reduce the apoptosis of the terminally differentiated chondrocytes in the growth plates, causing failure of mineralization, and thus is the end point of causing rickets in both the calciopenic and phosphopenic states. So the low phosphorus, because of it reduces the apoptosis of the chondrocytes in the growth plates, causes failure of mineralization, and therefore end results as rickets. So in a calciopenic state, you have elevated PTH in addition leads to bone resorption, which will radiologically manifest as osteopenia, subperiosteal bone resorption, periosteal reaction, and therefore in a calciopenic state, elevated PTH will worsen the rickets. Now, all of us know, as a part of NIC protocol, you know that we start calcium phosphorus. Some units may follow this, may not follow addition of phosphate. But roughly, to prevent, you see that TPN for calcium and phosphorus supplementation from day 1, fortification once you reach 100 per kg and 150 mg per kg per 25 mg per kg. So once you have the diagnosis of metabolic bone disease, the maximum calcium phosphorus intake, you look at are you already on a maximum phosphorus calcium intake? If no, your first step would be to optimize the calcium phosphorus
Dr. Ajay, I
Yeah.
think.
Am I audible?
Yeah,
Again, I lost the connection.
yeah, we just lost you. Yeah. Dr. Jagadeesh?
Yeah.
Yeah. All right. I think after your session, quickly we'll go for the question and answer. The lot of questions which have come up. All right.
So
We had
just
lost.
last few slides.
Sure. Finish it fast. Yeah.
So as I said, that once you look at the diagnosis of a metabolic bone disease, you maximize, you see whether they are already on a maximum calcium phosphorus intake. If not, your first step would be to optimize your calcium phosphorus intake. If metabolic bone disease persists, you treat based on your calcium phosphorus, PTH or TRP or vitamin D. Now let's see. The first option is to optimize your calcium phosphorus intakes, a calcium of 220 mg per kg per day, a phosphorus of around 110 to 140 mg per kg. See to it that your calcium phosphorus ratio is around 1.5:1 by altering your HMF sachet, whatever you're giving, and your vitamin D of around 400 international units per day. If the baby is already on maximum calcium phosphorus supplementation, then you have to treat based on the pathophysiology derived from your biochemical evaluation. That is, the first scenario, if you look at, suppose you're having, if he's not responding to your maximum dose of your calcium phosphorus supplements, then you know that you're going to do, if your calcium is normal, phosphorus is normal, vitamin D is normal, tubular reabsorption of phosphate is normal, only you're having increased alkaline phosphatase and a raised PTH, it could be hyperparathyroidism with subclinical hypocalcemia. In such a situation, phosphorus will not help you. Activated vitamin D, that means you're going to give calcitriol, vitamin D 1000 international units per day, oral calcium, and you continue your HMF at maximum dose. Whereas if you have another case scenario where you're having phosphorus, calcium will be normal, your tubular resorption of phosphate is also normal, but you're having increased alkaline phosphatase and PTH and a decreased vitamin D. So you know that you're dealing with a vitamin D deficiency. So you're going to add calcitriol, vitamin D, continue your calcium and HMF at maximum dose. So therefore, I'm just trying to bring to you that you also need to look at PTH in your workup. So when you're deciding, when you have a low phosphorus, the low phosphorus, I told you that you will definitely have an increased tubular resorption of phosphate, increased alkaline phosphatase. PTH will be low or normal in such a state. So that is when you're going to think of a pure phosphorus deficiency, and this person will improve with phosphorus with about 60 mg per kg per day and your HMF at maximum dose. So in summary, so you just have to look at when you have, as when you're screening, you're having a raised ALP, low phosphorus, normal or raised PTH. Look at PTH. If the PTH is raised, you're likely dealing with a calcium and a vitamin D deficiency. You start calcium supplements, optimize your vitamin D, stop phosphate supplements if it is prescribed, ensure that your calcium phosphorus ratio is maximum, that is 1.5:1 altering HMFs, whatever you're giving, and optimize. If it's not on TPN, you're optimizing your calcium in the TPN prescribed. But if the PTH is normal, more likely you're dealing with phosphorus deficiency. So therefore, PTH plays a very important role in your identification of what is the current problem, and therefore you consider phosphate supplements in this population. You ensure again a calcium phosphorus ratio of 1.5:1 to 1.7:1, and calcium supplements if needed to ensure the balance, and repeat your calcium phosphorus alkaline phosphatase every 1 to 2 weeks. So take home message is the metabolic bone disease of prematurity is, all of us know, it's under and mineralization of preterm infant skeleton from inadequate calcium and phosphorus. Clinically asymptomatic, it can be identified by biochemical screening and incidentally on radiographs, and severe metabolic bone disease of prematurity, providing at-risk infants with adequate calcium and phosphate through breast milk fortification or specific preterm formulae will help in prevention of this metabolic bone disease. And there is no single diagnostic test or screening test, with pitfalls existing in the pathophysiology of calcium and phosphate homeostasis. And you have to establish through the plasma parathyroid to determine the etiology of metabolic. Is it primarily a calciopenic or is it phosphatopenic? This will then direct your treatment with appropriate supplements while considering optimal physiological calcium phosphate ratios. Thank you.
Thank you, Dr. Jagadeesh.
Well-
It was very elaborative and very neat presentation covering most of the things. So I request Ajay to start the discussion and straight away take up the question. Over to you, Ajay. Dr. Ajay?
Yeah, I'm here, Prashant. Yeah, thank you so much, Dr. Girija and Dr. Jagadeesh. There are a few questions for Girija as well as for Jagadeesh. Girija, you were talking about hypokalemia. There are questions about hyperkalemia.
Yes, sir.
Dr. Ajay?
Yeah,
Yeah,
am I audible?
Yeah, please go ahead.
Yeah, this is regarding hyperkalemia. This is for Dr. Girija. In hyperkalemia, if the serum calcium level is normal, do you still go and give injection calcium for cardiac stabilization? This was one of the questions in the chat box.
Thank you for the question, sir. Actually, for the it is not about the calcium. We use mainly calcium gluconate as a membrane stabilizer over here. Can you hear me, sir?
We can hear you. Go ahead.
Yes, sir. Calcium act as a membrane stabilizer here. Calcium in the cardiomyocyte, it will bind to calcium calmodulin receptor and protein kinase 2, and it will stimulate voltage gated sodium channels, and it will allow the sodium to enter inside the cell, and it could cause for the DVDT, that is phase zero of action potential. Regardless of the calcium level, whether it is normocalcemic, calcium is used for the stabilizing for the myocardium. If in case of hypercalcemia or digitalis toxicity where you can't use calcium, you can try and use hypertonic sodium, that is sodium chloride or sodium bicarb. They too act as a membrane stabilizers.
Yes, Dr. Ajay.
Am I audible now?
Yes, sir.
Yeah.
Sorry, the connection is gone for me. I'm not able to hear.
Any more questions, sir?
Hey, how many milliequivalents
Dr.
to be given?
Ajay?
I have not read like that anywhere. How many milliequivalents to be given to rise 1 milliequivalent? I have not
Dr.
read anywhere
Girija,
like
sir?
that.
Yeah, hello, sir. Hello, sir.
Yeah.
You can start moderating. I think we lost Dr.
audible now?
Ajay. Yeah, Ajay. Yeah.
Yeah.
You're audible. Please go ahead. Please go ahead. Dr. Ajay, please go ahead if you're able to hear. Yes. Dinakar, sir, I've unmuted you. Please go ahead. Please continue the session.
Yeah. Prashant, can you just, you want to ask all the questions, my dear?
Okay.
Please ask all the questions.
Made with dextrose finger. 1 second. Sir. Any role of urinary calcium levels? Hypercalcium. Any role of urinary calcium levels? Can you hear me, Dr. Girija?
Yes, sir.
They're asking, is there any role of urinary calcium levels?
No.
Dr. Jagadeesh?
Yeah, there is a question for Jagadeesh regarding urinary calcium in hypocalcemia. How do you go about it?
Said you look at
Yes. Please go ahead.
you look at conditions where you're having a hypocalciuric. So you will some of the protocols, like you could look at measuring a urinary calcium for conditions where you're suspecting, for example, a calcium sensing receptor mutation, so which can easily be picked up by increased urinary calcium. So you can use urinary calcium when you're suspecting hypocalcemia, when you're having PTH, which is normal. When you, as I told you, the calcium sensing receptor will block the PTH and increase urinary calcium secretion. So it will be helpful in identifying somebody when you're suspecting a calcium sensing receptor mutation, where you're going to have increased calcium excretion.
Ajay? Dr. Ajay, yeah. Any oral preparation of phosphate available in India, as all calcium phosphate containing syrup has calcium to phosphate ratio of 2:1. Basically, they're asking the availability of oral preparation of phosphate in India.
So, yeah, oral preparations are not available. The same IV preparation, IV pot phos, can be given orally, but oral preparations per se are not available.
This is to Dr. Girija. Role of exchange transfusion in severe hyperkalemia.
What's sir?
Role of exchange transfusion in severe hyperkalemia.
In case of refractory hyperkalemia, double volume exchange transfusion is suitable, but fresh blood should be taken for that. Ideally, less than 24 hours whole blood. It has a role, sir.
It has a role. Okay. Glucose infusion. I think you have already told about the glucose insulin infusion dose for the treatment of hyperkalemia. Can you briefly tell it again?
Sir, it's like 0.05 units per kg of insulin with 2 ml kg of 10% D can be used as bolus. For a continuous infusion, 2 to 4 ml per kg per hour of 10% dextrose and 10 units of 100 ml of insulin at a rate of 1 ml per kg per hour. So.
Okay, so there is one question for Dr. Jagadeesh. Maximum, how many HMF sachets can be given to a baby in a day?
So it based on how much he's tolerating. That means osmolarity. Also, if you know that now we are having HMF sachet which can be dissolved in 25 ml of milk. So based on the amount of milk, and you're going to increase, make sure that by increasing the HMF sachet, you're just trying to maintain a calcium phosphate ratio of 1.5 is to 1.7 is to 1. So therefore, it is individualized for every baby and has and when and how he can tolerate.
There is one question which has come in Facebook Messenger, and it's a practical question as well. This is for Dr. Jagadeesh. So, what do you suggest for a routine? Do you suggest a routine? Suppose if baby is jittery, or if you are suspecting hypocalcemia, what is the interval with which we need to monitor the calcium levels? One, and suppose once if there is an extreme premature baby, routinely, how frequently we need to do a bone profile test for an extreme premature baby, and in bone profile, what are the specific things which you need to look at the values and we should be careful of? Dr. Jagadeesh.
Yeah. So as I told you that we'll be looking at the screening protocol is calcium, phosphorus, alkaline phosphatase. If it's an extreme premature, the more premature you start earlier, that is around 2 weeks you can start, and then follow it up 1 to 2 weeks based on the risk factors. So mainly we look at a baseline of calcium, phosphorus, alkaline phosphatase, and you would keep repeat. If it is normal, you keep repeating it weekly till term. But if it is abnormal, then in spite of maximizing your calcium and phosphorus intake, either by TPN or by a HMF sachet with supplementation, still you feel that it is abnormal, then you need to find out whether it is calciopenic or hypophosphatemic, and therefore you look at PTH, tubular resorption of phosphate, and vitamin D to help you to decide whether are you going to give calcium or you're going to give phosphate.
So what do you suggest for the routine use of calcium and phosphorus supplement oral? How much do you suggest for a premature baby on follow-up? Till how long they need to take? And how frequently is the best dose? The twice divided doses or thrice divided doses? What is the
So ideally, as such, most of the supplements are hyperosmolar and babies need to take it. So preferably would be thrice a day. And based on, you calculate how much on maximum HMF dose, and roughly, that around 80 mg per kg is oral calcium, which you're going to consider.
Okay, and there is one more question for Dr. Girija. What is the time range for treatment of hypokalemia, and time restriction for potassium infusion? How fast you can give, or what do you suggest?
Sir, it may take days to weeks together for the potassium in case of hypocalcemia for the potassium to get corrected. So it is not an within hours or anything like that. So based on the levels, ideally treatment is given. So if it is whether a baby can take orally or not, or IV fluids are required or not, based on that. And coming to checking of the phosphorus in mild to moderate cases, you can do daily basis, daily once, or twice a day in moderate to severe cases. Whereas in profound hypokalemia, where less than 1.5 is there, 1 to 2 hourly once it should be done.
All right, I think there are few people who have raised their hands. I'm going to unmute them. First is Dr. Asha Dur. Dr. Asha Dur, you can please ask a question. Dr. Asha? Dr. Asha? Dr. Asha, are you there? Okay. Dr. Gangawal has raised. I'm going to unmute. Yeah. Dr. H.N. Gangawal? Gangwal? Do you have any questions? Yeah. So I think there are okay. There is one more question for Dr. Jagadeesh, which has come now.
Yeah.
Any oral magnesium preparation, how long to follow up for osteopenia of prematurity? Can it lead to stunting?
Oral magnesium preparations I'm not aware of, but we usually give the IV preparation only orally, but oral preparations I'm not aware of.
Okay. Anybody can in the audience can raise your hands and answer this if you know. Dr. Dinakar sir? Yes.
Yeah, Prashant.
There is one question. Any oral magnesium preparation available? How long follow up for osteopenia of prematurity?
Hello, Prashant.
Is there any oral magnesium preparations available? How long to follow up for osteopenia of prematurity? Can it lead to stunting?
Osteopenia of prematurity, how much you are going to give the magnesium sulfate?
Yes. And is there any oral magnesium preparations available? Is what they have asked.
To tell you very frankly, oral magnesium sulfate, I don't know, because what we have seen is maybe for the constipation or something. But neonate, I have not seen oral magnesium sulfate. I think so. If can you ask anybody?
Yeah. Any of the participants can enlighten if they are aware of. So meanwhile, Dr. Ankur Rajvanshi has raised the hands. Dr. Ankur? Dr. Ankur?
Yes, sir.
Now, please go ahead with your question.
Just I was having a question to Dr. Jagadeesh, sir. That, sir, whether the calcium phosphorus preparation like Calcimax P, which is available in the oral preparations, those are better as a maintenance and as for the premature babies, preemie graduates going out for, or just plain calcium supplementation like we have like Osteopenia D and other things. That will be better. Which preparation do you feel is a better combination?
So that's what we use, Osteopenia D. But again, as I said, you should also consider, are we dealing with a predominantly calciopenic or a phosphatopenic? So look at that, and then
I'm here
you
talking about
supplement.
maintenance, sir. Like maintenance, basically for maintenance purpose, we sending the
Maintenance, yeah, Calcimax P is okay. We do the IV preparation. Some places use IV phosphorus also if it's not helping.
Okay.
Yeah, Prashant,
Yeah.
as Dr. Praveen told, oral magnesium, everybody will take their NIC necessary after they start osteopenia. But oral preparation, I don't know.
Okay. So there is one more participant who has raised the hands. Dr. Iranna B. Halemani. Please go
Yes,
ahead.
sir.
Dr. Iranna B. Halemani. Please, sir, please go ahead with your question. You have to unmute. One second. Singh, can you unmute Dr. Iranna who has raised the hands?
Yes, sir.
Yeah, we can hear you. Please go ahead.
Sir, extremely premature babies. Hello?
Yeah, we can hear you. Go, please go.
Extremely premature babies, for how many months calcium preparation should be continued?
Yeah. Dr. Jagadeesh?
Till 2 years, but you're going to monitor whatever you're going to give, like calcium. If you're going to give it as part of treatment of osteopenia of prematurity, you're going to monitor their levels. You're going to monitor calcium, urinary calcium levels if you're using very high dose.
Okay. Dr. Ankur has one more question. Please go ahead, Dr. Ankur.
Yeah, hi. This is question to Dr. Girija, madam.
Sir.
Yeah, madam. Just wanted to know, like, how much do you feel is the importance of salbutamol nebulizations in case of hyperkalemia in newborn babies?
We ideally use albuterol 400 microgram neb, and the response 60 minutes. Ideally, it can repeat again after every 2 hours also.
Okay, so but how is there any study, madam, or how is the response like? Response is because it's very difficult to titrate the response because we are doing simultaneously many other things. So alone, how much it's beneficial? It's quite good, or it's just adjuvant therapy?
Actually, in neonates, we won't use nebulized salbutamol as much. It's like IV salbutamol is the one what they use. But in a critically ill children, while you use salbutamol, we have to be cautious about the tachycardia and the hyperglycemia also.
Okay, madam. Yeah, thank you.
Yeah, Dr. John. Sir.
Hello.
Please go ahead, sir.
Hello.
Yeah.
Am I audible?
Yeah, you're audible, sir. Please go ahead, sir.
Some of the comments. First of all, great presentation by both the speakers. One of the few questions I wanted to answer, comment. One is somebody asked how many HMA or 45 can be used. As you know, in most of the cases, maximum amount of fluid or what we can get is 200 ml. Suppose a baby of 1 kg, then you can go up to 8 sachet because 1 sachet can be mixed with 25 ml. Another important comment I want to make, whatever 400 international unit of vitamin D that has been given by Dr. Jagadeesh, the recommendation that is above this what vitamin D is given through HNA. So it will come around 800 international unit if you calculate in a vitamin. So whatever recommendation has been given, 400 international unit of vitamin D, that is on the top of the vitamin D supplemented through HMO and milk. So it will come around 800 or something, 1000 international vitamin D. Third comment just wanted to make, although the PTS is recommended in most of the places in the OS because in their places separately the phosphate is available. So in many centers they used to use phosphate. That is why many babies they have problem because of only phosphate supplementation. But in our country, actually, most of you will agree with me. We do not use phosphate separately. We use calcium along with phosphorus or like that. But time has come. Even you use calcium, vitamin, then alkaline phosphatase and phosphorus. Once the calcium is low and alkaline phosphatase is high, then we think of giving metabolic bone disease of metabolic bone disease in prematurity. But alkaline phosphatase sometimes it is very late response. If you can use PTH, perhaps you may get earlier response. All of you will agree with me, once you supplement calcium and phosphorus, we can keep this supplementation up to 40 weeks of age. And if a baby is born around 26 or 28 weeks, by 40 weeks, they go home. By that time, we lose time to monitor them later. And the radiological changes that might happen when these babies are coming in follow-up. You do radiology, you do X-ray, you may find some demonetization of the bone. That is why I think we need a study to see the actually PTS, what is the PTS response of our babies. Because most of us, we are not using phosphate routinely. So once if you are not using phosphate routinely, so there will not be any influence on the PTS. So that is my gut feeling. Because most of the Western literature, what is there, they are actually, in their places, they are using phosphate separately, but what we are not doing. And one of the questions raised by one participant for what is the role of calcium in a case of hyperkalemia? See, calcium is given not to treat hyperkalemia. Calcium is given to stabilize the myocardium. So to take some time, to get some time actually. So it is not the question of what is the level of calcium during that time. And I think the speaker will also agree with me. Even these measures, that bicarbonate or salbutamol, these are all temporary measures. If there is a actually refractory hyperkalemia, you can do or dialysis. So these are the some few comments I wanted to make. Thank you very much. But once again, great presentation by both the speakers.
Thank you, sir. Thank you, sir. Dr. Dinakar, sir, would you like to add anything?
Yes.
Yeah, you're audible,
yeah,
sir.
Dr. Prashant. Yes, sir. Please, sir. So really from my heart, I am telling both the speakers are excellent. Number one. Number second, the PPT, what they prepared was an excellent both. The second thing, it is very informative to the fellows, postgraduate, as well as consultants. And even I have taken many clips, snapshots, said that it is beautifully presented. Thank you, Dr. Prashant, NNF and speakers, really good. And one more thing, whatever the potassium, whatever the calcium, only thing what we have to remember is it's very easy to remember. Dr. Prashant, can you hear?
Yes, sir. Yes, sir. Please go ahead, sir. Yeah.
So almost 80 people are there. I can tell only one thing, Prashant, about hypokalemia and hyperkalemia. For whoever the PGs who are staying or the consultant, easy to remember and exact values. The normal value of the potassium, everybody knows 3.5 to 5.5. See, everywhere 0.5, 0.5 is there. 3.5 to 5.5. Number one. So how to tell it is hypokalemia? Just decrease 0.5, 0.5. That means 3.5 to 3. Then 3 to 2.5, 2.5, less than 2.5. Less than 1.5 is very critical. Mild, moderate, severe, profound hypokalemia. Only decrease by 0.5, 0.5. It is very easy. Treatment also very easy in hypokalemia accordingly. So go to the hyperkalemia. So normal is 5.5. We know that in the preterm up to 6 to 6.5 or 6.7 or 7. Each book is telling different things. Some books are telling 6.7. Some books are telling up to 7 is acceptable in extreme premature baby or 6.5. So however, if you will take 6.5, just go 6.5 to 7, 7 to 7.5, more than 8. Once again, 0.5, 0.5, 0.5. Easy to remember. Mild, moderate, severe. So the normal value, if you'll know, you go 0.55 low, 0.55 up. So hyperkalemia, hypokalemia, easy to remember. Whoever the PGs are staying here, they can do that. Number one. Number second thing, even the treatment wise, beautifully Girija has concluded, easy. If hypokalemia is there, treat it, give either oral, IV, whatever it is, extra things. If hyperkalemia is there, goal 1, goal 2, goal 3. So come to Dr. Jagadeesh Somanna, beautifully he has explained. Slides were excellent. Only some hiccups were there in between because of internet. Otherwise, it was excellent. He is also told about hypo and hyper, both calcium. The thing is, kalemia, what? So what he has told is, think of common things instead of thinking the rare things. Think of common things, treat it. At the same time, if we will stick on to only calcium, what about phosphorus? Is there anything phosphorus we can give? It is not there. So what I am, orally it is available, but anything injection, no, other than TPN solutions. So what he has told, other one is, so think of magnesium also. So beautifully has concluded. I think so everybody is there. Over to Prashant. Thank you, dear.
Yeah. I think the slides in the presentation were very comprehensive and it has covered most of it. So you can access this slides and presentation. Please join our Facebook page, NNF Karnataka chapter, and YouTube channel as well. And we are there in Twitter as well. You can follow us and forget the link.
Prashant?
Yes, sir.
Dr. Prashant?
Yes, sir.
I think so. Doctor, can you unmute Dr. Girija? Just you want to add one word, my dear?
She can do it herself. 1 second, sir. Yeah.
Girija?
I just wanted to thank Dr. Dinakar sir for giving me an opportunity to talk here, and even NNF Karnataka, and even Prashant Gowda sir. And my thanks for my PG Dr. Ranjita for supporting me in my presentation. Thank you.
Yeah. Thank you. So thank you all speakers. Dr. Jagadeesh Somanna, you've done a wonderful job. Everybody is asking your presentation, both Girija and Dr. Jagadeesh Somanna. You can WhatsApp me your presentation. I'll put it in Facebook so that people can access with your permission, if it is okay. Because I'm getting a lot of feedback from Facebook and from YouTube as well, and from the chat as well. If you could give me the presentation with your permission, with both of your permission, I'll upload it in our Facebook so that they can access it whenever they want. All right. Thank you very much for all the participants. Thank you, Vijay sir, and all of them who have participated. I would like to thank all of our NNF office bearers, joint secretaries. Thank you, participants. We'll see you tomorrow. Thank you. Bye.
Thank you, sir.
Thank you, sir.